Right now I'd like to introduce Leanne Burns, who's one of the few nutritionists, I believe, who could actually speak about nutrition for carcinoid and NET patients. So, Leanne Burns.
Good morning. I appreciate being here and being asked to do this talk. I have, you can tell this accent, I'm from the New Orleans area, from South Louisiana, and so the travel was a great privilege to come. I'm excited to talk about this topic to patients because there's so many challenges nutritionally in this disease. So we'll go through this, and then afterwards I'll be available again. I'm one of those that don't mind. I really like the questions, so as you see me, feel free to come up and ask the questions. If I don't have an answer, I will get back to you. So today's topic is carcinoid cancer and nutrition. What's right for me? Back a few years ago, the American Institute of Cancer Research published the second expert report on food, nutrition, physical activity, and the prevention of cancer recommendations, where they reviewed over 1,800 literature documentations and research reports to determine really what are the right recommendations for nutrition in oncology and cancer prevention. And what they came up with were lists for weight management, diet, and physical activity. And if you have a normal GI tract and everything is functioning well, and you are considered to have had your treatments completed, we're listed as a cancer survivor, then your needs for nutrition are very similar to the general population. And this report gives you a great resource for what to do as far as keeping on a preventative track. Carcinoid is not necessarily one of the cancers that fall into this category, but I do have patients that do, and I want you to know that these are the guidelines that we do recommend for neuroendocrine as a way for healthy and prevention. The one focus that we use in carcinoid and neuroendocrine tumors is keeping an eye on the portions. If you were someone in the general population, we know that we really are trying to watch the amounts of the foods, and it's very important that we take what we can see on the left side as a very large plate with large amounts of calories, and we can take those same foods, space them out, put them on a smaller plate at 8 inches, and watch your portion size, take out some of the sauces, and this will give you a healthier diet. This also works in this arena for carcinoid patients because many times it may not be that you can't tolerate a food, but you can't tolerate high amounts of that food because of the amount of digestion and the amount of different insulin or different hormones that may be released after the digestion of these products. One of the preventative nutrition information that we have in the wellness area is for cancer prevention is to make it happen on the plate. And this is a program called the New American Plate. This is available through the American Institute of Cancer Research, and I want you to know that this is available. Very good information, very good recipes, and is great in the wellness arena. Nutrition, exercise, and cancer are not new. This goes back to this quote from many years ago. And it says, and it was felt that eating alone was not a way to keep a man well, but that you had to increase the exercise and the activities in order to provide a product of really good health. So this is not new, but it is something that's very challenging in the arena when normal doesn't work. And most of us know that in this arena, if you've had surgeries, if you have tumor secretion, that normal meals no longer work for you. And at this point, then we have to start changing the diet, changing the amounts, and using other issues in order to provide a really sound nutrition in order to give you everything you need in a day. So why do we do that? It's because we do have carcinoid syndrome. And these things do change the amounts and the types of foods that you can have. We do have flushing. We do have to change certain foods because certain foods, such as tyramine, because of the conversion to tryptophan in the liver, if you have liver involvement, may increase flushing. We know other things can increase the flushing. These can be controlled by diet or improved with diet at least. Fatigue is part of the treatment. We put people through really aggressive treatment, and we want to make sure that we're giving you the right recovery. And sometimes just the foods that you're eating can cause fatigue itself. High concentrated sweets, where your body's releasing a lot of insulin, it causes you to get fatigued afterwards. So we may have to change the amounts or the types of those foods. And then we have in just general oncology in areas where we're doing chemo and radiation and some of these surgeries, then you'll have some nausea, vomiting, and then of course diarrhea. And I work with Dr. Eugene Waltering in New Orleans, and he refers to my patient as the queen of diarrhea. So everybody needs to be queen of something, and that's my mark. So my job is to try to decide why you're having. All diarrhea is not the same, and my job is to decide why you're having diarrhea and make sure it's something that is because of the tumor and not necessarily because of other, and we'll talk more about that later. But one of the big problems that we have is that there's complications that arise just by some of the involvement in all the aggressive treatment, and that is sometimes we have involuntary weight loss. It means that you're not trying to lose weight, but you're losing weight anyway. You may be getting plenty of calories in, but if you're losing it because of the diarrhea or malabsorption, then it's just not going to be able to stop the weight loss. We also lose muscle mass, and we have protein loss, and we know when we do this, especially after surgeries and procedures, if you lose the muscle mass, it's very hard to regain it. If you gain weight afterwards, usually it's going to go to our abdomens, unfortunately, and not back to the muscles. So we bring in the muscle. We need to make sure that we're trying to retain the muscle mass and are doing something to try to bring it back with their exercise and activity. Reduction in the amount of consumed or absorbed nutrients. We know that sometimes just from poor intakes, from medications, we just are not able to get in enough nutrients. And then, of course, we also have medicines that are great at helping with control of the secretory diarrhea, but also that in its attempt to do that, it actually decreases some of the absorption of other nutrients, and we need to be careful with this. Decrease in the immune system and decreases in control of the bowel movements being one of the biggest problems. And, of course, what we really are all striving to do is to stop the reduction in the quality of life, because that's really the goal of nutrition, is to provide nutrition so that it increases your quality of life and does not decrease your quality of life. There's some markers that we use as nutritionists, and I'll say that because I get asked this a lot, because not all dietitians are trained the same. Not all dietitians have the same backgrounds. Oncology does have a specialty, and so that you may see a dietitian that's not been trained in these areas. I am an advanced practitioner nutritionist, and that means I'm just an old dietitian that has gone through the eras of nutrition where we had phases which we were able to do nutrition support and nutrition support teams. And this was a very aggressive, really in the area of post-op and in critical care, where we worked as teams. And this, along with everything else that changes with medicine, had its peak back in the late 80s and 90s, and now it's decreased because of funding issues. But these are things that we watch as nutrition support dietitians to make sure that as you lose weight, we identify it so that we can stop some of the malnutrition and the comorbidities that go along with this. Diarrhea and malabsorption. We know that some of this is from the tumor release. I say hormones here. It can be from the peptides that we've listened to earlier. Increase in the insulin. We talked about the insulin releases from the pancreas. This can cause a hypoglycemic reaction because you have too much insulin. We also have the serotonins, and we know that with the high serotonins, then we have some of the crises. We also have problems with side effects of the medications. Many of us that see patients that are on the somatostatic analogs, and we know it's great at suppressing and stopping what's going on, which is usually increased motility. So its job is to stop. Well, one thing, when it stops, it also stops digestive enzymes from being released, stops some of the digestive process, and so that we may have to do other things to offset this. And we'll talk a little bit more about this as we get into pancreatic enzymes. We have altered GI structure. Many people have had surgical removal of small intestines, large intestines. They have had part of their liver resected. There's things that cause the GI tract just not be able to absorb as well. And we have problems, which we refer to as a dumping syndrome many times, that's from the surgery itself. We also have times when you have when we reconnect you and it's causes an anastomosis where it's narrowed in the GI tract. I am from Louisiana, so I talk with my hands, so you had to see me drop something so I could show you. But where it's narrowed, and that GI tract just doesn't have the elasticity. And so sometimes foods are getting stuck, and it can't get through this anastomosis, especially post-op, and that can cause pain. So sometimes we have to really alter the diet because of these issues. Compromised GI function and organs from the pancreas and the liver where we just don't have as much release of our functionality. Sometimes post-op with some of the procedures in the pancreas gets very angry, and when you work with the pancreas many times, the procedure will increase what we call the metabolic rate. I mean, it increases the amount of calories you need in a day, sometimes to the point of a marathon runner. To challenge this issue, the surgeons that I work with did a liver resection on me last year, and sure enough, I did what my patients usually do and lost about 10% of my body weight in about 2 weeks. So this is living proof that my surgeons are really good, and they did know what they were doing, and that it just happens no matter if you do it to someone that thinks that they know how to stop it, because it's very hard to stop these surgical-related weight losses initially. That's where my job becomes very aggressive, is to try to stop some of these at some point. Decreased functions of the GI tract functional in the length. We've shortened the GI, and if you shorten the GI tract enough, then you'll have a short bowel syndrome. You just don't have enough length for it to be absorbed, the nutrients to be absorbed along the tract. And we have to alter, when you have a shortened one, you'll have to alter the nutrients and the types of nutrients that you're giving. This is where we take out a lot of the good foods, as people tell me, take out a lot of the concentrated sweets and fruit juices and things like that, so that we can stop the diarrhea, stop the motility in that area. Then we just have foods that are intolerant all your life. You may have been lactose intolerant. You have people that have always had GI troubles that are related to allergies and intolerances of wheat and different issues. These don't change just because you have this disease. If you had it before, you're probably going to still have it after you've been through treatment. So we have to remember that some of these are issues that have come over a long period of time, and we just have to adjust for them. Overgrowth of bacteria, when we've had you without any food for quite some time after surgeries, or your intake's been bad. Sometimes the bad bacteria in the GI tract overgrows what we consider good bacteria, and we have to make changes in the nutrition then to give you back some of the good bacteria. So what do we do? Well, the first thing in most of oncology is that we've really tried to increase the protein and calorie densities of foods. Most people do not increase their intakes. They actually have a reduction in intake, so it means that we have to make sure that you have enough protein and calories in every bite that you get, so that if you don't eat but 3 bites, you're getting something in those 3 bites. It's very important that we try to cause the densities. And then we try to increase the number of feedings throughout the day. We know that patients that go a long time without eating, and experience from just taking care of oncology for a long time, is that I found that when a patient goes long periods without eating, the body just doesn't get hungry anymore. This is a little bit of a challenge, and so we have to have you putting in something in your mouth about every 2 to 3 hours. And then if you are hungry, when you get hungry, you're hungry for 15 minutes. And then you're not going to be usually hungry for about 3 hours. So things that are easy to get to, it's very important that we have foods available, because what I see happen is if you are unable, by the time if you're hungry and you tell someone you're hungry, by the time they get it prepared, that 15 minutes is over, you're not hungry anymore, and then what I see is people quit asking for food because they don't want to bother anymore. Don't want to bother anybody. See this, and especially in men for some reason. It's even a little bit worse in my men patients. They just get where they just quit asking for food because they feel like by the time I get it, I don't want it. So you have to make sure that we're doing it at the right times and very quick and have easy access to these foods. Altered fiber. Fiber is in 2 forms. insoluble fiber, which is the fibers that we use in prevention of prevention of diseases and to increase the bulk of your stool. It's the part that has the structure of fruits and vegetables, and it's where the whole wheat and the whole grains come into play. These foods are really great when you have a working GI tract, and we're just trying to get everything to work normally. The other type of fiber is soluble fiber. And soluble fiber is oatmeal, the insides of the fruit pectin. And the fruit pectin is very important in the treatment of diarrhea because the insoluble fiber will actually worsen the diarrhea in most folks. And you need the soluble fiber, which actually helps with increase of water in the large intestine, as well as form fatty chain acids. So we know that the soluble fibers are actually more important in the treatment of diarrhea, and I usually take most of my patients initially at least, and then try to add back insoluble fiber. So actually changing, and I get slammed a lot on the national level because most of my patients are back on white bread and white rice, but those are very important during management of diarrhea because you're not going to tolerate the insoluble fibers. So doing those changes is really okay, and so it just is an education among dietitians actually, and so we really are trying to pass these words along. In low-fat diets, if you do not have enough pancreatic enzymes to digest fat, which is lipase, then you really are going to have to do one of two things. We have to either drop the amount of fat in the diet. This also happens when we take out your gallbladder. And to prove that to me, they also took out my gallbladder when they did the liver resection, and so now I know how much trouble sometimes you have with just taking out the gallbladder and having the bile salts and not having enough to do the digestion with. So we have to either drop the fat in the diet or give you a type of enzyme back, pancreatic enzymes back, into your diet so that you can digest the fats. I mean, the fats in the diet. This is very important. And we'll talk a little bit about the dumping. I went by it. I'm going to go back to the dumping syndrome diet. In the dumping syndrome, for people that have really rapid transit times, it goes from your stomach to the large intestine very fast. The first thing that I'm going to do or put on a meal plan is to take out concentrated sweets, and this includes fruit juices. These things increase the motility just tremendously. And so because I can't give you a pancreatic enzyme to change the sugar or to make that stop. So I need you to digest something that has calories in it. So I need you to digest your fats. I need that to be a source of energy for you. So I'm going to have to put back in a pancreatic enzyme or to help absorb it. So that'll be kind of a two-part. The dumping syndrome diet is also very important in treatment post-op in a lot of these patients that I have seen. And not only do we stop the concentrated sweets and the sugars in the diet or reduce these greatly, we also separate the liquids from the solids by 30 to 45 minutes. And again, that reduces the transit time, reduces the mobility or the time it takes to digest these foods. Take away extremely hot foods, any extremely hot cold foods. And also probably the hardest to do is that you really need to rest after you eat by about 15 minutes. Put your feet up, let everything sit still. I tell my patients, if your arm was broken, I could cast it. It's real hard to cast a GI tract. It's real hard to rest a GI tract. So the more, and my patients really love that because they usually turn around and tell their spouse, see, I can't do dishes after supper because I've got to rest. So it gives you a real good excuse that you do need to really slow down. Diarrhea reducing diets, this we see in all areas of oncology. And again, we adjust the fibers that we just spoke about, reducing the amount of insoluble fiber. We reduce the sugars in your diet. And we also alter some of the types of proteins. Some proteins are just harder to digest than others. One of these is, and we'll talk, talk a little bit more about it in a minute, but is red meats. Red meats take a lot of acid to digest, and for this reason, they just don't digest as well. And also, the first thing I tell people is that you need to chew very well. Use your teeth because we really want to have the digestion start in the mouth. You want that saliva to get around the food. So if you take 2 bites and swallow, it's just not going to be as easy to get you to digest food, and that's a lot of us do that. I mean, that's very common, two or three times, and not the amount of times that you need really to get this down. So we may actually get you to chop your foods beforehand, and post-op sometimes I even have to get people to use foods that are, I try to get foods that are naturally already pureed looking without giving you pureed foods because people don't like the way it looks, but that's when we use the mashed foods and souffles and things that are already chopped and you're used to. The low gluten-free and lactose-free, some people just have poor tolerances. We do have some true celiacs in this disease that they had this previously. It comes into the disease now. I think we may have, in oncology, we see sometimes people develop celiac, and if that's the truth, if that's happened, we'll have true gluten-free. I just have patients that don't tolerate the same foods that have gluten in them. Usually it's the wheat. And for that purpose, they'll not tolerate that. Milk is the same way. A lot of people just never tolerate it to start with, and this may become worse once we don't have the lactate, the enzymes released. Low tyramine diets for those that are flushing. We were hearing great things about the metabolism through the liver of these proteins. And tyramine does convert to tryptophan in the liver, and if the conversion is not good, then that tyramine in the diet actually will make the flushings worse. And these foods are things that are aged. The aging process causes the production of tyramine. The ones that come to mind that most people may be aware of are anything that's fermented. Alcohols. I think that's the universal one. Everybody knows that they may feel funny if they or get a flush when they have an alcohol. It also happens with foods that are aged cheeses, soy sauces, miso, anything that some of the broad beans that are fermented that we'll see. But it also can be just from the aging process of foods. When vegetables, and fruits ripen, the ripening process is what causes the overripeness is giving you the tryptophan. So you may be able to tolerate it if it's not unripened, but the overripening really does that. And we see that. Bananas is one area. We see some tolerance in bananas if it's a little bit on the green side and you don't have but a half a banana. But if you have a whole banana and it's been sitting around and the skin's brown now, you may very well have more of a reaction. This is also seen in people that have leftovers. So if you've had a food one day, and this is where it confuses people, you'll say, well, I ate it once, it was fine, but the next time I ate it, the next day, I just had problems with it. And well, if we try to encourage you to store your foods after you cook and not leave it out for a day or two in the refrigerator and then eat it, and that way you can get more use out of the foods, and the cost effectiveness is a little better. But sometimes it's this leftovers really can cause trouble. And in all areas of oncology, you never save anything over really 24 hours is my idea, never over 48. So food safety is a big issue, and using good food safety and good safety and preparation techniques, separating your meats and your vegetables, making sure that you don't contaminate between raw and cooked is very, very important, because that's just one other reason to get diarrhea, and we have enough problem already without having that come into play. The other one that is really interesting is the FODMAP diet. This research came out of Australia in 2009, and it goes back to the gassy foods that we've already eliminated many times from the diets, and classified as many of them are cruciferous vegetables, your broccoli, your cauliflower, the things that we knew were gassy. Well, this takes it one more step and breaks things down into fructo, ogleo, disaccharides, monosaccharides, and polyols. And these are, I have a list, and I think they may be on my website now. I'm with the Eichner-Kenner group in New Orleans, so I have, if not, it will be up shortly. But I had students, and so I had them put this into foods that are high in the FODMAP production and low. And the idea here is to take you off the high ones, and put you on the low ones for about 30 days. And then try to reintroduce the high ones back into the diet like we did the old elimination diet. So it's not that you'll have to always come off these foods, is our hope, is that we really can put things back. But wheat is in these categories, and that's why wheat is just not tolerated as well. And anything that ends in OL, mannitol, sorbitol, that's in this group too, and that's why we do see some complications in those foods. It's very important that we see these. All right. Alterations in the improves the intolerance, and we already talked about chewing completely. Very, very important, chewing. And then or chop it, mash it, increase your calories and density. This is, again, a repeat of a little bit of what I've said. Avoid the foods that we know have problems. If you had problems with things before, you're not going to improve after surgery. So remember that. If you never tolerate it, you're probably not going to start. Do the small frequent feedings. We need to get the calories in, but you're not going to be able to take high loads at one time. 6 feedings a day. And then adjust the liquids to meet the tolerances. If you drink too much fluid, it increases your diarrhea. If you don't get enough fluid, it causes dehydration. If you're a normal GI tract and you dehydrated yourself, you'll be constipated. I have patients that hold off their hydration because they know that it's going to decrease their diarrhea, and that sometimes can be very dangerous, so you really have to be careful about that. Adjust diet-related symptoms. If we have gas, then we can definitely put you on the diarrhea for a diarrhea diet or a dumping syndrome diet or the FODMAP diet. If you have increased nausea, we try to avoid red meats, again, just because they're very slow to digest. Fatty foods are slow to digest. They stay in your stomach too long and they cause nausea. Fat just is the last thing that leaves the stomach. Smells and color, the same things that make you hungry, from the color, the food, the smells, are the same things that make you nauseated. So in treatment, we really try to put everything white or brown on your plate during the times of very high nausea. And then, again, use the low-fat diets. If you're constipated, at that point, we do put back in the insoluble fibers and water because we need to be able to take care of that. Nutritional supplements, and I'm not talking about vitamins here. That is a whole one-day talk on replacement and staying off of that. But is that you need to know that there are replacements of nutrition. If you tolerate things real well and you're not having trouble with the dumping and a lot of diarrhea, we can use the Intact or the standard Ensure Carnation Instant Breakfast. If you tolerate the milk, they have a lactose-free one also. Breeze, which is a clearer liquid and doesn't have the thick, milky products. We'd use a lot of modular in surgical patients in our clinic, using Juven, which has the glutamine and arginine to help with the GI tract healing process. Very, very beneficial, I do believe, as a modular. Benical, which is just a high, you can get 375 calories in 3 ounces of this solution and add it back to foods. Medium chain triglycerides. When I need a fat product, I'm going to try to get a fat that doesn't have to go through the digestive process of the long chain triglycerides. Medium chain triglycerides are the foods that we used previously that made everything in the baked goods taste good, your coconut oils, your palm oils. And these can be prescribed, and you can get them in a pharmacy in a liquid form. And then I have some patients that are using coconut oils, and pretty effective. You can get those at the grocery store. And then we have specialty products. When you do not absorb correctly, we have to take a product down to a pre-digested product. And this is where a product called Peptamen comes in. It's already pre-digested. It uses medium chain triglycerides. This is very important in patients that do not tolerate the regular foods anymore. Vital is another one of these, very high in protein. Parative is one that's used post-op in a lot of facilities. This is very important. And then there's patients that just we're going to have to put on TPN for periods of time, total parental nutrition and IV solution to feed you. And this we will do that if necessary. Mediums, the medications, probably most of you know these. Anything that we need to reduce your motility, Lomotil or tincture of opiate can be used. Am I in the way here? Then their idea is to decrease the transit time and help give us enough time to reabsorb some of the water. And then there's some medications that actually just help with water binding, absorbed by binding the water. And this is the products, kaopectates, Dynagel, and then also some of the fibers, the polycarbs. Steatorrhea, this is what we have when many times as we put you on medication, the sandostatins and the octreotides to stop. It's the stop. Well, when it stops everything, it also stops some of the production of the digestive enzymes. So we're actually going to, you don't digest the fats anymore. And that's where this also happens after small bowel resections. Gallbladder removal can do that. Drug side effects, we talked about this. And then pancreatic insufficiencies, either by surgery or by the other medications that we may be using. And then we use a tremendous amount of pancreatic enzymes. I didn't know that this wasn't something was being done a lot until it was kind of a naive thing. Because I've done pancreatic cancer and pancreatic care for many, many years, and it's very much a part of that treatment nutritionally. And you need it to digest, especially fats. There's some people that can't access true digestive enzymes. It's a real pork product, and some of the patients, I have them just on the plant digestive enzymes, and they'll help some. They're not going to have the amount of lipase in them, but it'll help a little bit, and so we do use those occasionally. It's very important that I monitor as a dietitian. My job is to give you this information, but more importantly is to monitor whether I'm doing any good or not, and to make sure that I'm having symptom relief, that you're stabilized your weight. That's the most important thing, that I can keep your weight within a normal range. Normal protein markers, we use things to measure albumin, pre-albumin. You may have heard these before, and that's how I know what your protein's doing. Increased soluble nutrients, fat-soluble nutrients. A lot of people are having deficiencies in vitamin D when you have steatorrhea or any of your fat-soluble vitamins, A, D, E, and K, and we do use a vitamin that's made specially to carry over on a water molecule, so to speak, and we actually we do a lot of giving our patients these products. We use those back in the treatment of CF, cystic fibrosis, and it also works very well in this area too. And in vitamin D, using the sunshine when you can. I know that we talk a lot about, worrying about skin cancer, but if you get that early morning, that late afternoon, that's the best source. It's just real hard if you're not absorbing fats, we can give high amounts, 50,000 units, but if you don't digest fats, you just don't absorb those nutrients still very well, and it's what we're finding out in practice. We want to increase your food selection and then increase your quality of life. That's my job, is to increase your quality of life, to make sure that you're not too stressed over what we're giving you and making best choices. If everything's working well, I do recommend the American Institute of Cancer Research information or the Eat Right campaign that we just are changing by the USDA. If you have symptoms, we're definitely going to have to adjust your diet and fit your situation. Remember that everybody's different, and sometimes I see this when you get on chats and everybody says, well, she told me this and she told me this. Well, you're not all alike, so I'm going to tell you what you need, and then sometimes it may be a little bit different than the person that you may be visiting with. And with that, I'll just we're going to start with our questions.